It's time to start our webinar today. So I will give a brief introduction about our speaker. Good morning and good evening, my lovely participant for the ICC. We are so lucky to have Professor Fady to be our presenter today for our lecture. Dr. Fady, an assistant professor at the Cairo University's orthodontic department, and earned his dental degree from Cairo University in 1998. And he completed his master's in orthodontics in 2005 and his PhD in orthodontics in 2011, receiving the best PhD thesis for his works on alveolar, cleft lip and palate distraction. And in 2008, he became a member in orthodontics from the Royal College of Surgeons of Edinburgh, UK, and followed by a fellowship in orthodontics from the same institutions in 2013. He also became a fellow of the Royal College of the Physicians of Glasgow in 2023. Dr. Fady holds a patent for the F distractions for approximation of wide alveolar clefts, a research topic presented at the American Association of Orthodontics in 2014 and 2024. And he specialized in cleft lip and palate, digital orthodontics, skeletal and carriage systems, clear aligner, and orthodontic surgeries. And he is a member of the American Association of Orthodontists and the European Association of Orthodontists, and a fellow of the World Federations of Orthodontists. Dr. Fady lectured internationally, including for the American Association of Orthodontists and as a clinical consultant for Dentoran. And he also directed the MOSO-RCSED UK training program in Egypt, and he runs his private practice Peria Dental Clinic in Cairo. So today, Professor Fady will give us a lecture, MARPE, and as well, we invite three very famous the panelists to our panel discussion as well. So Prior, please introduce our panelists too. Thank you, Prior.
Thank you, Dr. Chang. And today we have three panelists, and they are attendees live from worldwide. And the first person I would like to introduce Dr. Nasim Magazzete, right? And Dr. Nasim just graduated PhD in orthodontics and residency training in orthodontics. And she specialized in the craniofacial and surgical care and dedicated to multidisciplinary patient treatment, deeply engaged in the sleep-related orthodontic therapy that I introduced her to everyone. And now she practiced in the private practice in California, USA. And the second panelist I would like to introduce, Associate Professor Dr. Marcy Shaiwara Gung. She is the chair of the orthodontic department of the orthodontic residency training program from Chiang Mai University, Thailand, and she also a subcommittee of Royal Dental College of Thailand for residency training program in orthodontics. And she treat a lot of cases for cleft patients, and sometimes cleft just has the airway problem as well, and she just did a lot of treatment for those patients. And the last panelist I would like to introduce, Dr. Viet Hong. I'm not sure. He's the father of Singden Clinic. And oh, sorry, yeah. And also now he's the faculties of the departments of orthodontics and pedodontics, faculties of dentistry, One Lang University in Vietnam. And maybe it's time for the presentation from Dr. Fady. Welcome, Dr. Fady.
So much.
Dr. Fady, excuse me, you probably need to check the style. We can check style again because now it turned black again. Yes,
Okay.
thank you.
So you can see my slide now, correct?
Yes, yes, currently we can.
Okay. When I go into a play to play, you can see the slide, correct? Can you see it
No,
now?
it's black. Yeah.
So I will just present from this mode better.
Sure.
Right.
That's okay. That's fine.
Perfect. All right. So thank you so much, everyone and the panelists. I'm really grateful to be invited to your prestigious channel, and I would love sometime to go to Taiwan. I didn't go there before. My PhD was about cleft lip and palate in orthodontics, and I did a patent as Dr. have said. That's why I'm really involved with the craniofacial, maxillofacial surgeons in my country. And also, I'm fond of doing like these type of mini screws all over. I put them all over in all different types and locations in the skull, and especially, of course, our topic today is about the MARPE. I'm celebrating this year 25 years in orthodontics. This is my Instagram account and my YouTube. I'm really a little bit busy to update these my social media, but whenever I have time, I do that. Will be very pleased if you can have a look on them. And of course, as I do in all my students and colleagues all over the world, I invite if anyone needs my help in consultation, and in their cases, I'm really will be of course want to help. I come from Egypt, and these are my certifications. I finished my master degrees in orthodontics 2005 and the PhD in 2011. Became cleared my exam in membership in 2008 and became a fellow of Edinburgh 13 and the Glasgow 23. And I always say in the beginning of any of my presentations that whatever technique you are using, if you are using labial orthodontics, lingual orthodontics, or aligners, you're going to use the TADs. So whenever you're gonna practice in the future, the TADs will be there, and it's really a life-changing. And here is one of the most important slides of today. It's all of my it's my classification. It is not copied from anywhere, but actually it is based on the evidence. So according to the MARPE, which is our subject today, if you are dealing with an early mixed dentition, which is a 6 to 9 years old, according to the evidence, there is actually the MARPE is not indicated because you are taking the same advantage of maxillary expansion with the conventional expanders. The second most important thing which most clinicians should understand is that there are very, very high failure rate of the mini screws at that age. So this is a real problem because you design the MARPE and then you get surprised that you're losing your TADs. And when you are losing your TADs with the MARPE, you should stop the maxillary expansion and redo your appliances in most of the situations. So that's why the evidence is telling us that mini screws at that age is extremely horrible instability, and there is no need actually when you are taking the same advantage of maxillary expansion with other conventional appliances. However, when we are moving to the late mixed dentition, actually also I will not use a MARPE in that age, except in two exceptions. Number one, there are early loss of the deciduous teeth, and I have a case to show you what I mean about that, whereby the teeth are shedding and there are early loss of the deciduous dentition and there is no enough dental support. So in that condition, I will go forcibly to the MARPE to solve the problem. The number two, of course, if I am dealing with a skeletal class 3 case, to actually have a very good anchorage in the maxilla to do the traction or do the maxillary protraction skeletally rather than dentally. When we move to the early permanent dentition, 12 to 15 years, I will not do a MARPE for an expansion because the suture is most probably open and all of the evidence is telling that. However, also there are only one exception if you are dealing with a skeletal 3 appliance. We all know from the evidence that patients above 10 years of age with the skeletal 3 malocclusion, they do not respond skeletally well with the traditional face mask. So you have to do something else. You have to reinforce your anchorage with MARPE, either if you are using a face mask or using a bar, a mandibular bar, it doesn't matter. You have to use a skeletal anchorage in the maxilla to reduce the dental effect of the face mask or the maxillary traction. And of course, that will make your life easier. In 1 year older than 15 years, actually in my practice, I usually suspect that there are some intermingling of the sutures happened. I will not say complete fusion that will resist the expansion, and I will go for the MARPE with this above the 15 years old, which is starting from, for example, 16 years old to 18 years old. Actually, we all know about the papers that are talking about assessment of the suture using cone beam CTs. But actually, if you have any ethical or legal issues in your country doing cone beam CTs to assess the suture, I'm telling you that I'm 100% successful doing the MARPE in that age without any cone beam CTs and with great success. And this is also stated by many of the evidence. Actually, the older than 18 years old, which and going through the mid-20s, that might be questionable, whereby the maxillary suture might have experienced a lot of intermingling and a lot of fusion that will actually resist the expansion. And this is I really recommend in that age to do a cone beam CT to assess the situation of the suture. The most important thing actually in doing the MARPEs in that age, especially, that you have to have the consent of the patient to be accepting that he will go to do a SARPE whenever the suture did not open with the MARPE, and you should take this authorization from the patient before the treatment and before doing the MARPE, because there is some percent of failure that you might experience with the MARPE, that you should go for the SARPE, and this will make a big problem with our patients in our clinic, because we did not introduce this what we call it the risk of failure from the MARPE, and then we should interfere now with the surgery. Who will accept the surgery and who will not accept? Who will pay for the surgery? So it's very important, because when you do a lot of MARPEs in your practice, you know what I'm saying, and you have to be in the safe part with your patients. And I will go back to the classical paper of Professor Bertha Melson, whereby she was explaining how the suture is during the maturation with a tortuous line, and then these comes in more intermingled together and making them more tortuous, whereby resisting the opening of the suture until, of course, the full fusion of the suture. I explained earlier that during the late mixed dentition, whereby you have experienced early loss of the teeth, the permanent teeth are erupting and so on. You have an E that you cannot support upon because it is poorly destructed. So here in this condition, I will go for the MARPE. If you have legal issues with the radiation of the cone beam CT, you should follow the classical paper of Wilms et al., whereby he was explaining about the T-zone, and I always keep my mini screws behind the third ruga area, which is dentally confirming, most probably in most of the situations, along with the first and second premolars. So in this patient, we did the expansion, and the very nice thing is that I keep the expander in place. I do not remove the expander. I know that there are articles talking about leaving the expander 3 months and 6 months, but actually, I think this is not enough for complete regeneration of the bone in the newly open suture, and I keep actually the expander in place until I finish or nearly finish the treatment, or unless you need the first molar to do something else. So it's very important to know that the best retention appliance for the MARPE is the MARPE, and I tried very different clinical appliances and they didn't actually work out, and it's easier actually and costly effective to use the same appliance. You can see that we started with the C, D, and E with a compromised E, and D that they were exfoliated or extracted actually due to their poor prognosis, and then I kept the MARPE in place until there are a full eruption of the teeth. Actually, this is the best space maintainer, I know. And then you are waiting for the eruption of the canines, and then after 17 months, we are nearly finished with the full permanent dentition, and I go in minimal amount of time to do the braces. Actually, you should be very smart to know when to introduce the braces and the best timing to do the braces with the MARPE. The MARPE did the job, expanded the jaw, let the teeth to move by what we call it, the driftodontics, and then you can see how the occlusion is very nice and how the patients are changed a lot. If we go to the original category, which is the late mixed dentition, as I explained, and then we'll go now to the early permanent dentition. And I told you that my first indication with the MARPE at that age will be a class 3. So it is very advisable to add buccal arms to your MARPE, and then you start traction with whatever technique you want, with a face mask or with a mandibular Thomas bar. It doesn't matter. There are many evidence in the literature talking about there are insignificant evidence. Some are talking about that the face mask is a little bit better, but I will tell you my clinical experience about that whenever I do the Thomas, the mandibular, the Thomas mandibular bars in the mandible, I will enlarge this a little bit. I have a problem usually with the success rate of the mandibular screws. And remember, with assisting the MARPE in skeletal 3s with this type of appliances, if one of the screws in the mandible you get lost, you will have to stop the traction. And this is actually if you are a little bit confused, what should you use? Should I use the face mask, or should I use a Thomas mandibular bar supported with 2 screws, or the mento plate? I have a note about the mento plate, which needs a surgical intervention to place it, and need a surgical intervention to remove it. I'm actually not fond of the mento plates for that, because the patient is already, he's young, to go for this intensive surgery before and after treatment twice. So personally, this is personal preference. Actually, I don't like the mentoblade for that. The second thing, the risk for the mentoblade is that also they are supported with screws. If one of the screws failed on one side, you have to stop the treatment. So what I want to say is that if the patient can tolerate and cooperate with you with a face mask, after doing a lot of these mandibular Thomas bars, I actually recommend going with the face mask better than the mandibular Thomas bars because of the frequent failure rates. Especially remember that there are many evidence talking about high failure rate in the young age, which is below 12 years. So also we all know and experience in our clinic that we have a high failure rate of the mandibular screws. Some evidence are talking about as low as 50%, and I agree with that, especially in the lower anterior segment. There are frequent inflammations and you have to deal with it, especially if the patient is uncooperative and is still young and is not doing the proper oral hygiene measures. So it's up to you according to what you like prefer in your practice to do, and I give my insight about that. Of course, when you are using a face mask, you have to, the traction force should pass through the center of resistance of the maxilla, which is pretty high, and it's very difficult to have your line of action of the force near to it. So you have to bring the buccal arms as anterior as possible and drop this T-bar of the face mask as low as possible to try to approximate the line of action of the force to the center of resistance of the maxilla. Otherwise, if you are applying the force below the center of resistance, you will experience a counterclockwise rotation, which will not be that favorable. Why? Because it will open the bite. So actually take care about the skeletal threes with high angles, and I usually prefer doing the MARPEs in these cases. Also, you can add the hooks instead from the buccal side. You can add them from the palatal side, two from the palate. And also I will talk about, I want to share my experience about frequent failures and breakage of the buccal arms while using the face mask, which makes sense because you are applying maybe 400 or 500 grams of force per side. That might break the buccal arms, which act as a cantilever. So like, give yourself another means of attachment of the elastic. Why not to make a plan B for you? As Berta Milson once said to me when I met her in one of the European Orthodontic Society meetings, you have to do a plan B. You have to have a plan B, especially in mini screws, especially in MARPEs. So if the buccal arms are fractured, you have the palatal hooks. I will go to my category then, and I will move to that age of 16 to 18 years old. The MARPE is highly indicated in this age. And I always say in my presentations about MARPE, you have to understand that the orthodontic literature introduced the MARPE to substitute for the SARPE, to save the patient from the invasive surgical procedure. And if you don't know, the SARPE, if the patient is indicated for a SARPE, for example, anamandibular advancement surgery, you're gonna do the SARPE before the braces in the beginning of the treatment, and then do the braces, and then do the second surgery, the mandibular advancement surgery at the end. So what if we are successful in avoiding our patients the SARPE procedure or the SARPE surgery? That will be amazing. So for this age, 16 to 18 years, it's very advantageous to use the MARPE, and this is one of my cases whereby, especially when I'm dealing with these skeletal three types, but actually it was non-growing patient, He was around 18 years old. I did the MARPE first, and then I extracted the teeth to align the completely impacted and blocked out maxillary canines. And I managed to actually retrocline the lower incisors, or actually distalize the whole mandibular dentition. Again, this is a dental treatment because he's non-growing, using the class 3 elastics supported from the MARPE to the lower arch wire. And in that situation, I recommend using a very rigid wire in the lower arch, so that, and in this protocol, actually, I'm following the protocol of Professor Chris Chang about that, whereby he have shown us how the lower occlusal plane is tilted, is actually tilting up from the anterior segment and going down in the posterior segment, whereby they are actually not retroclining the incisors. You are actually playing with the occlusal plane. Of course, it's very advantageous to use the digital orthodontics, of course, and whenever indicated, I use the cone beam CT with the STL of the patient to superimpose them, and then do the search for the best site for miniscrew insertion for the MARPE. Actually, there are two schools here. Some prefer to do the monocortical insertion, and some prefer to do the bicortical insertion. I think the evidence is not clear that much about that issue. However, why not to go bicortical unless there are any further evidence that say that there are no difference? So to do that, actually, you have to go for the cone beam CT, and this is if you want to be pretty sure that your screws are going really bicortical. You have to do actually a cone beam CT. So you can do an isolated cone beam CT with a low resolution to reduce the radiation dose. This is how I do it. I actually intraorally on the soft tissue level, I go at the third ruga area. In this procedure, it's really similar. You have to keep away, of course, from the apices of the roots of the upper incisors. Otherwise, the patient usually will complain about some tension at the upper incisors immediately after insertion of the screws. So I keep them well behind to be able to design the screws, especially if you want to go bicortical. You have in the anterior palatal area not less than 8 millimeters of bone. That is very, it's really super and amazing for your anchorage to do the MARPE. Something else in most digitally, especially the digitally designed MARPEs, but actually the conventional lab design MARPEs too, there are very important recommendation that the two TADs should be extremely parallel to each other. And this makes sense because the MARPE you will see in the coming videos and pictures, it will land like, I call it landing on a helicopter on both heads of the screws in the same time. Imagine if your two screws are not parallel to each other, this will not permit the accurate fit of one of the arms, or actually the whole MARPE should be, you should redo it again. And then, of course, after doing your design, one of the things actually I really recommend is doing the stent digitally designed. I tried a lot to insert the two screws manually with aorta stent parallel to each other, but I failed in 90% of my trials. So that's why I really recommend doing a stent or a guide for you for proper insertion of the proper parallelism of the screws, and not only that, but also to control the vertical insertion of how vertical you will insert the screws for the MARPE, especially if you are looking for a bicortical engagement. It is mandatory to use the stent or the guide for that. And then I talked about the suture maturation, and that's why I classified my category to the 16 to 18 years old, whereby most evidence are telling us that there is no much concern about the fusion of the suture in this age, and the most problematic part is above the 18. So there are like 10 studies in the literature talking about, they classified the suture maturation in 5 stages. They are telling us that in stages, of course, the stage A is like the mixed dentition. It doesn't matter. It's patent already. The stage C is like 12, 13 years, but actually correlating these stages with the dental age might be not accurate, especially it differs from race to another. And this is very important because the ages I just mentioned in my category, it works on my Egyptian patients. Maybe you can modify these chronological ages according to your race and according to your population. So what the evidence tells us that at stage D, this is the most problematic stage, whereby the MARPE might work or might not work. In stage E, definitely the MARPE will not work. There is complete fusion, as you can see in the figure, whereby you cannot split the maxilla anymore. And this is where the axial cuts from the paper, whereby where they classified them into 5 stages. As you can see here, in all these 4 stages, you can see the intermingling suture in the middle, and then all of a sudden in stage E, you can't see this suture anymore. That's why it is very important, if you can do the cone beam CT before doing the MARPE, you will take the advantage of knowing what are the hazards and what are the complications you are waiting for in the future, and save yourself. This is very important in our practice, and save yourself from any mishaps with the patient. To tell them, sorry, the MARPE is not working and we have to go for the SARPE. Why not? Didn't you inform me before doing the procedure? This is my point. And I based actually my category on different evidence. This is one of them, whereby they found that according to the chronological age, which is stated in the mean, you can see that the stage A is 6 years, which is he's still the deciduous dentition or the early permanent. Stage B, 9 years. It doesn't matter. At that age, there is no need that. Of course, there's no need for cone beam CTs. We actually know that they are open. In stage C, it's 14 years, 0.8. That's why I'm telling you, below the 15 years, I don't do the cone beam CT, and I don't care for this assessment. I brought this evidence to explain how I did my category. And for stage D, which is the problematic, this is what I'm saying. From the 18 years or to the older, you can face patients with a stage D and a stage E as early as 20 years. So that's why you have to be careful with the suture maturation, especially after 18 years of age. And we'll go for the MARPE versus the SARPE. And I explained myself earlier actually about that. Always in skeletal 2 patients, when you go for the mandibular advancement surgery, you will develop a posterior crossbite, which I can see in the pre-treatment visit actually with my pictures. And this is how you should do the SARPE with the splitting and so on. But actually, this patient was 18 years of age, and I saved her from a SARPE because the suture was patent. And actually, in all my cleft lip and palate cases, and all of my surgical cases, and all of my syndromic cases, I do the cone beam CTs as a routine. And I think I backed up with the European guidelines of radiology for that. back then, in this case, whereby she needs a mandibular advancement surgery, I did the MARPE first, changed the arch from a V into a U-shaped arch, which is in the future, after the mandibular advancement surgery, I know that she will develop this type of crossbites, and this is the patient after the mandibular advancement surgery. I think the results is amazing on her profile, and the occlusion is very good. And I also want to talk about the self-ligation versus MARPE. Actually, my students know me. I'm not a self-ligating guy, especially when we go for expanding the arches with the self-ligation. I prefer actually the MARPE, and this is one of the cases where I prove myself. One of my students insisted upon trying the self-ligation of expansion, and it ended up by proclination, severe proclination of the teeth, and opening the bite, especially in high angle cases. It is really problematic. And this is actually, I'm not saying that the self-ligation is not working, but you should do a proper patient selection before expanding with self-ligation. For example, in the patient with a deep bite, whereby if the expansion with the copper nitride wires did some dental effect, you will not be that will not be dangerous on their final malocclusion. And you can see the patient cone beam CTs from the videos, whereby you can see how the roots, there is no enough labial bone on the labial surface of the upper incisors. As you can see also here from these axial cuts, there is barely labial bone after doing this type of expansions. Again, if it is the self-ligation is working with the proper patient selection. All right. So what I do in my practice is that when I have that great amount of posterior crossbite, and especially can recognize in skeletal 3 cases that there are dental compensation whereby the lower molars are tipped lingually, therefore you should compensate for correct the posterior crossbite and for this uprighting that will happen to these molars during the braces treatment. So that's why this is an aggressive posterior crossbite for that, and I go for the MARPE. This is for the amount of the crossbite. The second thing for the intrusion, and I will show you one of the cases whereby actually the bite is closing using the MARPE, as in this case I did the MARPE, and then you can see this is what I call the pin last approach. I will explain it more if I have time at the end, whereby you do the MARPE and then you put the screws inside. This type of MARPE I really indicate in skeletal open bites, because surprisingly what I found in one of my cases is that the bite is closing while during and after the expansion, using this type of the pin last approach MARPEs. So this patient taught me that I will do the MARPEs, especially the pin last approach with the high angle cases. I will not try definitely in high angle cases with reduced overbites with self-ligation. I'm very happy with the MARPEs in these problematic cases. A very quick slides about how to place the palatal TADs, especially the MARPEs, especially for the beginners. You have to use simply the contra angle. I always say to my students, never use the long version of the screwdriver in your during insertion of any type actually of the palatal screws. So this is the patient whereby I'm placing the screws without a stent, and I'm trying to place these 2 screws parallel to each other if you're not using a stent. So my philosophy is that place the first screw first and then not to the end, and then try to imitate the angulation and the inclination of the first screw while inserting the second screw using the contra angle. This is if the stent is not available in your practice, or you are maybe lazy enough not to do that, doesn't matter. I have cases that I placed the screws without the stent, and I was successful too. But actually, it is a very steep learning curve to place these two TADs really parallel to each other manually. It needs a little more experience. So doing a stent with the beginners is much more recommended. And then these are the different types of contra angles in the market. The Dentaurum has this piece you can buy it, and you can place whatever contra angle you need on that. It works like that. When you move this part is rotating, and also it controls the torque of insertion. And this is very important to talk about that the torque of insertion of the palatal TADs, there are a little bit resistance during the insertion. The recommendation for the torque insertion for the mini screws, there are some diversity in the literature. Some are talking about as low as 7 Newton centimeter. Some are talking about as 20 Newton centimeter. But actually, I will go for the higher torque insertions, especially for the palate. I think that the palate, it needs some more torque during mini screw insertion. I will adjust the contra angle, whatever it's manual or electric, on approximately 15 Newton centimeter to 20 Newton centimeter. This is one type also of the manual types. It comes in one piece. And this is the famous, of course, the electric driver. Actually, it is made for the implants, not for arts. The placed caps and so on, and the abutments and so on. It is very advantageous for us. You cannot use, of course, the endo electric driver, because the maximum torque in the endo ones is 5 or 7 Newton centimeter, which is not enough, and you will ruin it. So that's why you have these dedicated screwdrivers, whereby the torque insertion starts from 10, which is more suitable for our choices. And then we have the cheaper version from Jeep, China. And of course, if you have in practice the dental motor, you will also be very good with that. But please, you have to adjust the torque, as I've said, to around 15. Start with 15 Newton centimeter. And when you have a resistance, you can maximum have raised your torque insertion to 20. Otherwise, I really don't like to raise the insertion torque more than that. You might experience fracturing, and this will be indicated for what we call it pre-drilling, before doing the insertion. Don't forget, if you are using the electric drivers, to set up the speed up to as low as 15 RPM, round per minute. 15 RPM around. If you are using less than this, maybe the screw doesn't have enough speed to penetrate the cortical bone. If you use a higher speed than that, you might experience bone regeneration and bone heating to the bone cells, which will cause bone death around the screw, and this will lead to immediate failure, or what we call it the near failure, which comes, for example, the second visit, you will visualize the looseness of the screw. That means that you have heated up the bone cells, and the bone just throw the screws to you again. Don't forget to follow the T-zone, as I've said, and this is the proper angulation actually of the contra angle to insert the palatal screws. Usually I have like a general rule for mini screw insertion, whereby you have to be perpendicular to the surface of the insertion. I usually follow this concept in most of the mini screw insertions. Nowadays, of course, we are going digital, and we are doing everything digital with whatever system you are using. The STL files of the adapters, of the abutments, of the screws are offered free from different companies to you, so that you can include them easily into whatever software system you are using. So in the last part of my presentation, I will talk about the difference between the pin first and the pin last approach. And I told you that when you go for the pin first approach, it is very important to use the stent to have these two screws parallel to each other. It will be more, it will make your life easier actually during the chairside time, especially if you are a beginner. It's very important to visualize, of course, the nasal canal in the middle to avoid, of course, we are already placing paramedian screws, so no problem with that. The problem is with the roots of the central incisors, so you have to keep away. And this is a monocortical way of doing it. If you want to go bicortical, you have to cross the level of the cortical bone of the nasal floor. And then it's we have two approaches, either going fully digital workflow or doing it manually, taking impression. If you go manually taking the impression, ask the company you are using, do you have any impression caps? I think they are offered by the Forestadent and also with the Dentaurum system. They are fixed to the top of the pin, and then I put them on the top and I take the impression. I started doing this impression making with alginate and I stopped doing them with alginate. Actually, the rubber base is far better, far accurate, and so on. My recommendation is that using this very large syringe to inject some material around the impression caps and then go for the full impression making with your tray. Hopefully, these impression caps should be brought upon inside the body of the impression material, like that. And then fixing the transfer caps on bring the Thomas lap pins in the impression caps. The impression caps actually will finally go inside the impression material while taking them out. And these are the alginate impressions and these are the rubber base impressions. I recommend actually the rubber base, of course. If you're going to use the light body first to inject around the impression caps and then with a one-step rubber base, heavy body rubber base silicone, additional silicone rubber base impression material, this is the most, I think, the most ideal. If you don't have the light body, you can also go with the heavy body only. And this is how we fix the pin first approach MARPEs, whereby the appliance itself is landing like an helicopter, as I've said. Actually, the abutments and the band or the shell, if you are doing it digital, should sit together. Maybe the abutments should precede the band insertion a little bit more to ensure that the abutments have capped the screw heads properly on top of the screw heads. And then you start doing the expansion. And this is the patient. She's around 19 years old. We did the expansion with a pin first approach. And then we ended up nicely with a very good occlusion and very good arch at the end. The one advantage of the pin first approach is that you can remove the MARPE at whatever stage you want and then do another appliance. For example, I did in a palatal appliance. It's like similar to the mousetrap, but it's not actually a mousetrap, whereby these wires are deflected towards the center of the palate, and then I just hang them with a steel ligature on buttons on the second molars to intrude the palatal cusps that during the finishing and alignment stage. And actually, this is the big advantage of the pin first approach. The pin first approach needs more work, more experience, more digital orthodontics work, and specific Miniscrew systems that can work with that. But the good side of them that you can remove the MARPE or the appliance without removing the screws. And this is very important to understand, that if you are placing the pin first approach, you can remove the MARPE and put another appliance, or actually repair the MARPE if something happened. Actually, we need nowadays from the professional clinicians all over the world to talk about actually complications of the procedures more than the procedure itself. Actually, it will be more beneficial to the beginners to know that. And then if you are doing, these are the inserting the lap pins from the system. You are using the same system, of course. It simulates the Miniscrew system. This type of technology we already adopted from the implants. So the surgeons and periodontists know these steps so well more than us. The implants actually were ahead of us in these procedures. So you just place the lap pins or the analog pins inside the impression cap and then pour the impression. Like this, if you are going, of course, the conventional way. And I will show you how you go with the fully digital workflow. But of course, the fully digital workflow has its flaws actually and the drawbacks, and it needs more experience. I think it needs a very experienced also lab technician with you. This is how I pour them manually, and then you will develop a model with the 2 pins and do whatever appliance you want to do with that. And actually, aside of the MARPE, this is my best approach of doing what I call it, the NANS modified transpalatal arch design without the acrylic. I just do the wires supported on these on these mini screw heads, and that's it. I don't use headgears anymore for anchorage. I don't use the TPAs or NANS for anchorage. This is how I do it nowadays with going fully digital. I've told you before, the abutments from each company, they offer free on their site the STLs, whereby you can import them in the system, and then you should fix them or transfer these abutments on top of the heads, as you can see in this video, whereby it is exactly the same as recommended by the company. Again, take care. We're talking about the pin first approach. It is problematic in the conventional way and in the digital workflow way. Why? Because it needs more steps and it needs more experience. Finally, I recommend going with the stent if you are using the pin first approach, and you can see that the end of the Thomas adapter is flushed with the stent. That means that it will, whenever you reach this level of vertical insertion, you have to stop when the adapter is flushed with the cylinder of the stent, as you can see in these pictures. All right. And I reviewed the last month a very nice paper that will be nearly published soon. They were talking about the 2 types of stents, whereby they are only supported dentally or a full coverage. And they concluded that the full coverage is much better. So whenever you take more soft tissue, more teeth with you, the accuracy of the stent is much better. And you can see how the adapter is flushed with the stent. And this is how I insert the screw inside the stent. We'll finish this video, and then I will go for the last part of the slides, which will be explaining the pin last approach, which is much easier. There is no need for a stent because you already designed the lab designed already the position of the eyelets on the cone beam CTs. Fix the stent. Of course, I try fitting the stent on the STL model of the patient. Everything is fine. I call the patient, to give him the appointment. the patient is still feeling some pain. And I always say that the mini screw insertion for our patients, whatever you're doing, should be completely painless. Actually, there is no need that we were taught many years earlier before to partially anesthetize our patients so that they will tell us, all right, I feel some pain, so you have to stop because you approximate the roots. Actually, there is nothing like that, in my opinion, because actually the neurovascular bundle is on the cortex. So whenever you are penetrating the cortex, the patient will feel pain. So don't please completely anesthetize the patient. I usually use the 1/5 of the carpool. This is extremely enough to completely anesthetize the patient, and then the procedure should be 100% pain-free. Remember that you will stay with this patient 2 years with braces treatment. So don't let him, when he see you again in the coming visits, to be afraid of you, and to remember the painful mini screw visit procedure. This is my opinion. So I will try inserting the screw until the adapter is flushed with the cylinder that is predetermined already with the STLs that are offered from the companies, different companies, that they are comparable with the length of the adapter already. Everything is pre-calculated, and then I will stop insertion actually when the adapter is flushed with the cylindrical part of the stent. All right. In the final stages of the presentation, the pin last approach, every mini screw system now is adopting this procedure, whereby the clinician should only do the scan and then send the scan to the lab technician, and then you go home after, for example, 1 week, for example, according to each lab. Yes.
Receipt from Nana Yahan Bigasabajan.
Yeah, please go ahead, Dr.
Please
Fady.
go ahead. Yeah, I
All
think
right. Okay, so every system nowadays from different companies are adopting this type of pin last approach, whereby everything is done already by the lab. Of course, the position of the eyelets on this patient should be predetermined together. Don't leave the technician to place these eyelets alone. He doesn't know the info. You should know the info. You should lead him. So I tell him, for example, but actually this is my lab work. I'm really fond of doing the lab work in my practice. So you just inform the lab technician about the proper position according what you learn. If you have a cone beam CT, you can recheck with the cone beam CT and so on. And this is a only 5 minutes approach, whereby I'm inserting the pin last approach without any stents, without any hassle, and everything. Of course, the patient is anesthetized before inserting the appliance, and then cementing the appliance. If you are cementing with a band or cementing it with a shell, it doesn't matter. Of course, cementing with the shells in the digitally printed MARPEs, you have to understand that we need a very good resin cement material to bond the metal to the enamel structure, and you should use a dedicated metal primer for that, and most importantly, to do good sandblasting and roughness of the shell before cementing it with the resin cement material. In this video, I'm doing it conventional, cementing with a glass ionomer. Please go for the type 2 glass ionomer cements. I like the ones that comes from GC. They are, I think, the dual cure. You can mix them and then cement the appliance and do the light cure afterwards. They are so reliable. They have considerable amount of fluoride to protect the enamel, remove the excess, and then the most important part, inserting the screw. It is very important in this technique to keep the arms that are coming out of the hyrax short as possible. Otherwise, the longer you go, the more cantilever design you will experience. That means that the eyelets on the anterior part will sink while inserting the screw. And this is very important. The second most important thing is that if you are seeking for rigidity for the skeletal 3 patients for the MARPE, I really recommend going for the pin first approach and not going with the pin last approach, because the pin first approach, maybe in some systems, during the pulling of the maxilla, nothing will stop it from sinking inside the soft tissue. Anyway, I like the mini hyrax designs, because in my country, actually, we have extremely constricted arches that the larger bodies of the hyrax will not fit. And that's why explain why the eyelets are a little bit not parallel to the soft tissue, a little bit with angulation, because we don't have this flat part in the anterior part of the maxilla, which is extremely constricted. That's why the eyelets a little bit with a tip or angulation. And then you just start to drop the screw inside. When screwing the pin last approach, the pin inside the ring, please, you have to keep the screw extremely in the middle of the eyelet. Otherwise, the threads of the screw will hit the boundaries of the eyelet while insertion. Like exactly I'm showing in the in this video. You can see the eyelet is a little bit tilted, and also my hand is a little bit tilted to go directly in the middle of the eyelet, and then you are done. You have to know when to stop, because in the pin last approach, there is no stand. There is nothing will tell you when to stop. You have to stop whenever the screw touches the eyelet. Otherwise, you will experience sinking of the eyelet. And I prepared a digitally workflow of the pin last approach, but I forgot to include in the presentation, whereby I designed the eyelet 2 millimeters away from the soft tissue to avoid any soft tissue sinking of the appliance. Whenever you have this type of eyelets with a thickness, and then you will leave a little bit more space between the eyelet and the soft tissue, it is mandatory to go for the longer screws. Never use screws below 10 millimeters in these type of appliances, because already you lost 2 millimeter eyelet thickness and 2 millimeter, 1 or 2 millimeter with relief from the soft tissue. So I usually go with a minimum of 10 millimeters. And you can see how the arch is constricted so that the tads are extremely approximating each other, because I don't have enough space. This is what I'm talking about. We have racial difference. Every country and every doctor knows the type of population. And this is the eyelets in place. And of course, this is what I'm talking about, the complications, sinking. Already the eyelets are synced inside the soft tissue, so we have to take care about it. And this is the patient immediately after expansion with a thorough expansion of the suture. Don't forget to tell the patient that you will develop a midline diastema. Otherwise, the mother or the father will be very worried about that. And you have to assure them, of course, never insert or remove the screw with straight screwdrivers. And this is a really challenging case whereby she's a flat profile, non-extraction profile with a class 2 subdivision, with a class 1 on the canine on the right side and a full unit class 2 canine on the right side, whereby if you go for an extraction, I will pull out 3 units, which will be too much for this patient. That's why I did correct the posterior crossbite and then started using the T-loop or rectangular arch wire as anchorage for the class 2 elastics. And this is how the shape of the arch changed dramatically after expansion. And this is how the things is going. And then I go with a class 2 elastic supporting the torque with a 19/25 with a T-loop arch wire. And this is how we finish the occlusion. With a solid class 1, the profile is much better, but I didn't have a permission from the patient's parent to bring her face to you now. So the patient's face is much better, even we didn't extract, and the overjet is solved with a very solid occlusion. Thank you so much for attending my very quick and short webinar. I hope I delivered what I want to say, especially for the beginners. And again, I'm really pleased to be on this prestigious platform, and I'm looking forward to meet again very soon. Thank you so much.
Thank you so much, Professor Fady. It's a very like great and excellent presentations. I have learned a lot because I have lots of questions about that, but your presentation already answered all the questions that I have. And
Thank you so much.
the next one we go for the panelist discussion. The first one I would like to invite Dr. Nazim to give some thoughts and experience about the MARPE treatment.
Fantastic. Dr. Fady, it was a pleasure to listening to you and also witnessing your enthusiasm while explaining. That says everything about how much you care about your patients and your profession, and how much, you got us engaged in this. Whenever I was just listening and then you were talking with enthusiasm, that says everything, and your patients and students are so lucky. So thank you so much for that. I just wanted to, add there are some questions from the audience that we are going to go through it, but just I'm going to, for maybe less than a minute, I just want to add how important is this concept of expansion. Even if the patient is going to surgery, I did 1 year post-residency fellowship at University of Michigan in craniofacial and surgical fellowships, and some of our, patients, syndromic, cleft lip and palate, we did like 3-piece expansion in the surgery planning. But then I learned, which I didn't learn it through my fellowship, but after that, with my colleagues, I learned that how important is that to expand if we can with MARPE or SARPE or DOME. Because, if we do 3-piece, we're going to affect the muscles of, breathing, and also, so this is one thing I just wanted to bring
Yes,
attention.
and I want to add a very important point about that, is that
Yes.
according to the Prophet, the hierarchy of stability of the surgical procedures, the surgical expansion comes to the lowest one of the procedures.
Yes.
So
Yes.
actually, some are confused about that. When you go for surgery, that doesn't mean stability.
Exactly. And then when in Turkey, we always only look at, the occlusion and decide whether this patient needs expansion. Even if you want to extract it, maybe we need to do expansion, and the effect of expansion in the breathing and, the increasing of the nasal mucosa, and, the gift that we give the patient. You showed some of your adolescent patient. So there's a gift you're giving to them. So when they become, older and in their, late, 60s, 70s, they can breathe better. So this is amazing. So just wanted to bring a light into these 2 points. And I really, really enjoyed your talks. Thank you so much.
Thank you so much.
Thank you so much, Dr. Nazim, for sharing your experience about the treatment about the MARPE. And the second panelist, I would like to invite Professor Marasi, please.
Thank you. Thank you very much indeed for a very interesting presentation. My interest would go to the cases that young, like the age of 9 to 10 years old, that you suggested that in the case that have severe sclerosis, that you might consider using MARPE. But we know that in young kids, to expand the maxilla, normally we can achieve that without invasive protocol. So do you have any criteria that the case that we choose to use MARPE for them? And have you ever got any complications?
Yes, as I explained, am I still sharing my screen, correct?
No.
You can see my screen,
No.
correct?
No, we don't see, but
You don't see. All right. I talked about in the category I made that for the early mixed dentition, the MARPE is never indicated below the 9 years of age. In the late mixed dentition stage between 9 and 12 years, the MARPE is not indicated, but only in two exceptions. The first one, as I've shown you, the case with early loss of decidual dentition, you don't have any dental teeth to support your expander, and even if you are doing it with the bonded hyrax, also you need some teeth to bond them, especially in the late mixed dentition. For if you do for example, the bonded hyrax, and then you recognize that there is an abscess in the upper D's after placing or in the middle of treatment of using the bonded hyrax, you have to stop and pull out the bonded hyrax and pull out or deal with this deciduous tooth with an abscess. So in my opinion, as I've shown in one of the cases, in that case, I will go for the MARPE. And the second thing, I will go for the MARPE with the class 3s, of course, in that age. Above 12, I will not use our MARPE. From 12 to 15, I will not use a MARPE for expansion. I will only use the MARPE with the face mask in skeletal 3 patients. So this is what I've said during the presentation.
yeah, so my point is, in the age like 9 to 10 years old, how severe or how small of maxilla that you would consider using MARPE?
Of course, in severe cases, when you have a great amount of posterior cross bites, or the reverse of ridgette is too much, I recommend to go for the MARPE in that stage. Take into consideration about the evidence telling us about that the face masks above the age of 10 years, it means that you will have only dental effect. And I think that the MARPEs, introducing the MARPEs at that age, at 10 or more, for class 3s, it will be a game changer, because it will, according to the evidence, of course, it will encourage more skeletal movement of the maxilla.
Okay, thank you very much.
Thank you.
Thank you very much, Professor Marcy. And the next one, I would like to invite Dr. Viet. Please share your experience about the MARPE.
Hello, Professor Fady. I'm enjoying your lecture so much, and I really interested in your workflow is really the same with my workflow in MARPE. But my workflow, I am using the Odyssey software also, and I design the semi customized MARPE same as with you. But for I am using, and I am doing the research about the MARPE, about the when we need the MARPE, and which one the amount of the Miniscrew we need and the position of the Miniscrew. So how do you think about the Miniscrew from the Korea or MSA or something like this? I always see you use the 2 Miniscrew, and it's on the anterior side. But when we use the 2 Miniscrew, sometimes we can hit the lost one side, so maybe we can have the problem during expansion. So far, my experience, I always use the 4 Miniscrew to be sure we can do the expansion. If we fail 1 Miniscrew, it still can be expanded for the bacillary. How do you think about it?
Yes. Of course, my presentation today was only 1 hour. I didn't have much time to speak about different items, but regarding your question, the 2 Miniscrew MARPE versus the 4 Miniscrew MARPE, we are nearly finalizing a randomized control trial at the orthodontic department, Cairn University, under my supervision. And I will tell you why we managed to do this RCT in the beginning is that I really believe that whenever when we go beyond the first molar area, the amount of the posterior bone is very minimal. I can say I measured them in many patients, and they are only 3 millimeters or 2 millimeters only, and this is very important. The most important thing in the posterior screws, you must understand that there are more risk of soft tissue coverage in this area too. So actually, I will go for the 4 Miniscrew MARPE. If the posterior crossbite is too much, we want to expand really posteriorly more as much as anteriorly, whereby to open the suture nearly parallel as Won Moon recommended in his articles. I will go for the 4 Miniscrew MARPE, of course. But take into consideration is that whatever length of the screw you will use in the posterior part, you will not engage in the bone more than 3 millimeters. Because actually, you don't have that much amount of bone in that posterior part of the mouth. That's why what Professor Moon is calling for bicortical insertion to just increase the chance of engagement of the screws in this very minimal amount of bone.
Yeah. Okay. Thanks
And
so much
of course,
for your sharing.
yeah, thank you so much. And of course, I think the anterior screws is much more higher than the posterior screws.
Yes, of course, I agree with you. So that's why I'm doing the research finite element about which 2, 4, or 6 Miniscrew is better for the skeletal expansion. And especially if we have time in the future, how we can discuss about the tooth bone or bone appliance is better for which part and clinical case. Thanks so much, Professor.
Don't forget to add what we have said now about the rate of expansion. How frequent you will open the expander. I think we need a lot of evidence in this topic, because some of us are going very rapid, 6 times per day, and some are going the rapid protocol, which we're taught with 2 times per day, and some are recommending only one turn per day, and some are recommending one turn only every other day, and 2 articles published later on by Jorn Ludwig. They talk about measuring the stresses that regenerate in the maxilla during the expansion, and when the stresses drop down, and then you should turn the hierarchs. So actually, I think the topic of the rate of expansion should be more and more digged in our future research.
Okay. Thanks so much for the presentation and your sharing, Professor.
Thank you.
Thank you so much, Dr. Viet. And the last one, I would like to invite Professor Lo to give some thoughts and experience about this treatment.
Hi, Dr. Fady. It's really great to listen to your talk, and you have a very nice result. First of all, I'm a surgeon, so I'm not, familiar with this technique, MARPE technique. But I look at your result. I saw some of the class 3 patients you can treat with MARPE, and quite nice results. So I just like to have your comment. When do you choose MARPE? When do you choose SAPI? Or when do you send patient for orthodontic surgery?
Yes. So you're talking about the line between the MARPE and the SARPE. The
MARPE, SAPI, and orthodontic surgery. Yeah.
An orthodontic surgery, yes. I will talk about the orthodontic surgery first. When you are going to operate, of course, this is also according to profit. When you are going to operate in the maxilla, for example, maxillary impaction or maxillary advancement surgery, you will do the expansion surgically during the procedure of the low for one osteotomy. So this is a one procedure, and it's done in the theater once. Then comes the SARPE. If you are not going to operate in the maxilla, and for example, you are going to operate on the maxilla by expansion and the mandible by advancement, for example, which is the famous example of the gummy smile, the skeletal 2 mandibular deficiency with gummy smile. I will go for the if you are going to impact the maxilla together with it, you will go orthognathic surgery surgically. But if you are not going to operate on the maxilla and you're going to operate on the mandible, as the patient I've shown in the presentation, I will do the SARPE in the beginning of the treatment and the mandibular advancement surgery in the post-orthodontic phase at the end of the treatment. Talking about the skeletal class 3s, the patients should respond very well according to the evidence below 10 years of age without a Miniscrew-assisted expansion. However, at 10 of age, it's not about the suture that is starting to fuse, but actually the cranio-maxillary sutures, which are joining the maxilla to the cranium. These are trying to have greater resistance during the maxillary traction. And in that condition, above the 10 years of age, it is more likely to do a MARPE to increase your opportunity to have more skeletal advancement of the maxilla. And here I want to report the paper in 2000 by my dear professor and colleague, is my friend Professor Eric Cleo, where he developed in the year 2000 the technique of ultramic, whereby alternating rapid maxillary expansion and contraction. I usually this technique when the patient is older than 10 years, to just relax, not about the mid-palatal suture anymore, but about the cranio-maxillary sutures. I want to loosen up the maxillary sutures, especially around the age of 12, 13, and 14 years old, where you are still trying to correct the skeletal 3 non-surgical. It is really smart to introduce something that can release the sutures, the cranio-maxillary sutures, like ultramic.
Mm-hmm.
Okay, thank you. One other question is that I'm taking care of the patient with cracked even palate, and many of them have contracted maxilla. What is your opinion about this patient with contracted maxilla?
I did a survey among, I think, 150 orthodontists and surgeon, and I asked him a couple of questions. In a nutshell, what will you do in expansion in cleft lip and palate? Actually, if he's young, there's no dilemma for that. There is no controversy for that. You will just do the fan type expander, the quad helix, and so on. He's still in the young age, around 9 years or 10 years of age. He will respond because the suture and the alveolar cleft is not grafted yet, and everything is open. But actually, if we are talking about a more older age of cleft lip and palate, there is big controversy in that age, which is actually, I'm talking about the patients above 12 years, 14 years, 15 years, and so on. Some responded in my survey talking about that the suture is still patent because there is will never happen a union in the sutures, in the palatal sutures with cleft lip and palate cases. It's already open. So actually any appliance without going for surgical intervention will do. And some responded that, of course, as we go for the rules in orthodontics in the normal cases, above 15 years of age or so, you have to think of surgical expansion. So actually, in the problematic age, what I'm talking about, around the 15 years, we need a lot of studies to talk about what is the best approach. Can I expand the already open suture in cleft lip and palate, or should I go for more surgical intervention? Take into consideration that the SARPE is not only for opening, or the surgical expansion is not only for opening the suture, it is also to loosen up the resistance coming from the zygomatic buttress. So if you take this point of view, that you want to loosen up the maxilla from the zygomatic buttress to avoid what we call it the Y shape or V shape tipping, alveolar tipping of the teeth during maxillary expansion, cleft lip and palate, at least he should go for to osteomize the zygomatic buttress to lessen the resistance during the expansion above the 15 years of age. So actually, I think there is no clear protocol for that. Especially for cleft lip and palate, that was my PhD. So the cleft lip and palate patients, the treatment plan should be really customized in 100% manner. You cannot apply solid rules on these patients.
Thank you very much.
Thank you very much, Professor, for the creations. And the next one, I would like to go for Q&A from the audience, because today we has a lot of creation. Perhaps maybe I just pick some of them, and then I'm gonna send all the creation to Professor, and you can write it down, and maybe everyone can read in details, and like they can review all the treatment protocol or the treatment technique that you would like to share to them. So the first one, I would like to ask the question from Professor Shabir Hassan. When using MARPE in cleft palate with the palate bone defect, what specific consideration taken for screw placement? Yeah, I think everyone just curious about this one. If you would like to expand the palate in cleft patients, so what is your protocol?
In my protocol, as I've said to Professor Lou, if the patient is before the grafting phase, the secondary grafting phase, which is between the 7 and 9 years of age, I will just do a fine tap expander. If I have a posterior crossbite, I will go for a normal Hyrex. I can use also a quad helix, which is very efficient appliance if it's done well without any heat treatment from the lab technician. It will be very efficient to expand the maxilla, and then I send the patient for alveolar bone grafting. And then I wait for 3 months at least for the success of the bone graft to consolidate with the entire arch. And then when I take the permission from the surgeon to start, I will start with the second phase of treatment of braces.
Wow, that's wonderful. Like you try to expand first and let the bone healings.
Yes, I like expansion first. Maybe there are very slight exceptions.
Okay, and the next question just relate to this treatment as well. Like just in case the kid just need to wear the face mask with the expansion. Also, what is the recommendation for minimum daily wear for face mask to achieve max orthopedic effects while balancing with school and daily activities with the MARPE cases? I think maybe focus on the young and children. Yeah. Ensure the patient.
Of course, he can't use the face mask for during the activities, and I think also during the school, which makes for us taking out not less than 8 hours from the 24. So we have only 16 hours. So I encourage him to sleep with the appliance and go for a full 16 hours per day. Otherwise, there will be a progress, but not that fast in comparison to patients with high cooperation with the face mask.
Thank you. Thank you so much. And the next one is the question from Dr. Sharkil Ahmed. In the context of Miniscrew first approach in MARPE, if primary stability software Miniscrew is not achieved upon initial placement, is it necessary to repeat the entire procedure, or can alternative stabilization or repositioning strategy to be employed?
Yeah, this is a very high-tech question. So in the pin first approach, if you were going to place the screws and then take the impression, you are in the safe side. You just repeat everything and so on. But actually, you have to ask yourself a very smart question. Why didn't you have a primary stability in the beginning? Is there any defect in the bone of the patient, which is actually in 90% of the situations that will be the answer? So that might make you to exclude the MARPE as a treatment plan and think for alternative plans, because simply the patient's bone is very soft to accept or to increase the success rate with this patient using the screws with a MARPE. If you did the one-step digital workflow and then you place the screw and then the appliance, the lab designed for you and printed for you the stent, and then he prefabricated for you the MARPE, unfortunately, very bad news. You will throw everything in the trash and start from the step one again. I think there is no, because you made 2 holes inside the bone, and these 2 holes will not refill by bone and mature by bone except after 6 months or 9 months. So what will you do? You will postpone the whole treatment to after 9 months, for example. This is not practical, I think. So actually, that is why I'm saying, and pardon me, I didn't have much time to talk about the fine details in each topic. It's a very big topic. That's why this is one of the mishaps of doing the full digital workflow.
Thank you so much. And another question, if we focus on the MARPE in adult, and if we do the rapid maxillary expansion, how to avoid to widen the face when we proceed the MARPE, or you have any protocols to recommend?
Actually, when the patient is indicated for a MARPE or a SARPE and so on, there is deficiency in the cheekbones and so on. I think so. In my patients, I have this observation. So actually, this is in the favor of the patient's face. He will look much better, I think. So why do you want to stop it from happening? So you have to discuss it with the patient. You can tell. It happened actually in 1 or 2 cases. She was really concerned about any facial changes. She doesn't want any facial changes to happen during the treatment with the MARPE and so on. And I told her, actually, we are doing or expanding. When we're talking about the pure skeletal expansion of the suture, it is not more than 3 millimeters. So I don't think that the MARPE will will do any significant facial changes to the patient. But of course, you have to be very cautious with the psychologically alert patients that they told you, I don't want to have any facial changes. The psychological management of the patient here is very important, more than the treatment.
Thank you. And I will go for the last question from the audience, from Dr. Iftiha. Indication for pin first or implant first approach other than learning curve experience, and you're expert as well for that. I mean, this doctor might ask about indication for the pin first that you recommend. Could you want to share more about this one? Hi, Dr. Fady. Maybe like we lost some connection. Maybe I go to the next session. I have one conference to share to all of you before we ending. Is he back? Nope, right? Before we ending this session. So I would like to introduce. Oh, sorry. Okay, so I would like to introduce the meeting, the Worldwide Orthodontic Meeting that will happen in Rio de Janeiro. Is the World Federations of Orthodontics 2025. It will happen like on the October 22nd to 25th. Oh. And then many numerous world-renowned attorneys that will give the presentations on this conference, such as Dr. Favier or like Dr. Benedict Wilmans. If you want to learn about the screws as well, he has the palatal expansion screws, or even Professor John Ludwig as well from Germany, or and many more speakers that will be on this conference. And now like the e-poster submission deadline just extended. So if anyone would like to join the world largest orthodontic congress, and please feel free to submit your e-poster. The deadline will be end on June 23rd, 2025. And thank you. Yeah, I would like to share this one, and maybe I will give more details in our Facebook group. And if you want to see more information, please go to the website wfo2025vo.org. Thank you.
Thank you, Prior. Thank you so much. And thank you, Professor Fady. Today, we really learned a lot about all kind of scenario, and that is the very good option to use in the MARPE to figure out maybe the trouble or the difficulty in those the patient who in need, especially for the cleft patients. Even I am a surgeon. Professor Low is a surgeon too. We still really enjoy all you have shared with all of us. Especially, ICC webinar is not only for the surgeon, even for all our orthodontics friends, like the prior, like all orthodontic experts from all over the world. We all enjoy to collaborate it, and we like to work together to treat for those patients. Only you, only me, we need to work together to figure out those problems together. Yes. So thank you every time. I really enjoy the topic. That is quite good and to help our kids or our children's. And of course, I have to announce our next ICC webinar too. The ICC webinar that is 108. The presenter is the Dr. Susanna Falato, and her topic is the myofunctional therapy for pediatric obstructive sleep apnea. So the date is at July 13th. Of course, always welcome for your participation, and that is a very interesting topic as well. Okay, so thank you so much, Professor Fady, and especially thank you for three very good expert, our panelists. Yeah, Professor Marasri from Thailand, and Professor Viet from Vietnam, and the Professor one that is
Yeah.
from California,
Yes.
but now
Yeah.
he's in for the Professor Nassim. Yeah, thank you for all of your coming that give us a very nice panelist discussion with Dr. Fady. Okay, time flies.
So much.
And good morning and good evening. Thank you for all of your participation and coming, and see you next time. Okay, Prior, you have any closing remark to want to address? Prior?
For me, I really enjoyed this session, and I think like as Dr. Professor Fady said, like maybe we need to know more protocols for like each groups of the patient, because we cannot treat this treatment like to like the same apply the same protocol to every patient, like in different ages or maybe different races, because I believe in different races, we have different craniofacial feature. Maybe we should study more about this one, and it's gonna help a lot to a lot of patients, not only for CLEP, but maybe SDB patients as well. And the next session that Dr. Cho introduced, I would like everyone to join the myofunctional therapy, because it's very helped for orthodontic patients as well, especially the patient who have sleep breathing disorder. So if we know and understand more about the myofunctional therapy, it's going to be great to our patients. And maybe next is the time for the group photo, Dr. Cho.
Yeah. I almost forget it. It's very important section. I would like to invite all our participants. Yeah, please stay on turn, and please turn on your screen, please, with our presenter and our panelists together. I would like to take the group photo with all of us. Hello, my friend. Yeah, thank you very much. Thank you very much. Yes, welcome for come join with the group photo together. Yes, and then I will count to 3, and please give me a big smile. Okay, and have a good day with a lovely smile, and have a good one with a lovely smile too. Okay, count to 3. 1, 2, 3. Cheese. So good. Thank you so much. And I have tagged the ICC webinars, the information in Facebook in our chat room. So refer to all of you if you want to today's webinar summary, and we have recorded the video as very kind with the sharing from Dr. Fady, and probably tomorrow or 2 days later, we will make it public for all of your references. Thank you again. And good night, good morning, have a good day. See you next time. Bye-bye.
Bye.
Bye-bye.
Thank you.
Bye-bye.
Bye.
Thank you, Professor Nassim. Thank you, Professor Rasri. Thank you very much.
Thank you.
Thank you,
谢谢。
Fady. Thank you, Professor Fady. 谢谢.
Bye.
Bye.
Have a good night. Have a good day.
Thank you so much.
Okay. Thank you, Prior.
You.
Thank you, Junior. Okay. Good job.
ค่ะ
Common Cup. Okay.
Yeah.
Bye-bye.
Bye bye.